Right, I see we have a couple of people have joined us, and thank you very much for joining us this morning. I'm Vicky McGrath. I'm Chief Executive at Rare Diseases Ireland, and today I'm joined by Dr. Ellen Crushell, who's a metabolic specialist in Temple Street Children's Hospital. Before I get into the main, I guess, conversation, the main point of today, I just wanted to maybe recap for everybody on the Get Rare Aware campaign and the reason that we run this campaign. For your information, this webinar will be recorded. There is a Q&A function, and if you have any questions, please do feel free to ask. You can ask at any stage during the meeting, and we'll try and get to all of them over the coming half hour to quarter to an hour. I would also, just before I guess embark into the campaign or into the talk about the campaign, I just want to thank our sponsor, Roche, who is working with us on this project and helping us to I guess raise awareness through Get Rare Aware. So the reason, the name of the campaign, Get Rare Aware, I guess there's a need to continue to raise awareness of rare diseases generally in the country. There's a lot of misconceptions around what is rare and what does it mean to have a rare disease, and that there's only a handful of people in the country living with rare diseases, and we really need to make sure that people understand that this is absolutely not the case. While individually a rare disease, there may not be all that many people with a particular rare disease. In some cases, there may only be one or two, but collectively, when we put all of the 6,000 plus rare diseases together and all of the patients together in the country, there's 300,000 plus. So that is as common as something like diabetes. So really, when you juxtapose those together, everybody knows what diabetes is, but lots of people don't know what a rare disease is. And certainly, I guess one would have to say the nuances of individual rare diseases, it's not practical to think that everybody will understand each and every individual rare disease, but certainly we can do more to ensure that people understand that there are lots of rare diseases and lots of people living with them. Last year we ran the campaign. It was our first year of the campaign, and we ran it around genetic services, which is something close to the rare disease community, as a lot of these conditions have a genetic component to them. And as a result of the campaign, there was over 6,000 emails sent to TDs. They didn't get 6,000, not everybody got 6,000 emails, but collectively across the campaign, there were 6,000 emails sent. So most TDs received 15 or 20 different emails from their constituents, and it really helped to raise the profile amongst the political classes. There was 50 different parliamentary questions, so those are questions to the Minister for Health. Some of them would have been fed through to the department, and some of them might have gone through to the HSE. But overall, it really did lead to I guess, raising awareness around rare diseases and around the need for proper genetic services to lead to a diagnosis. This, I guess, work is ongoing. We do have a new genetic strategy in the country that was published actually shortly before we started the campaign, but there's still, recruitment to be done and just keeping the profile high for genetic services. And there's been a number of leaders' questions over the last 6 months or so around genetic services and the recruitment and movement of the lab to the new children's hospital and things like that. This year, obviously, we've taken on the challenge of newborn screening, a little bit more maybe niche as a topic, as many people go through it at birth and don't ever think about it again unless they're an expectant parent. It doesn't cross people's thought process. But notwithstanding, it's a hugely important piece of I guess, of healthcare services in this country and, across Europe and globally. We all are very familiar with the importance of screening following the cervical check scandal. And really, I guess, newborn screening is another tool that would help us to eliminate some of the diagnostic odyssey. We have some very recent data from a European research that shows that it takes typically about 4.5 years, 4 years, 6 months, 7 months across Europe to get a diagnosis. In Ireland, we're over 6 years is the average time to get a diagnosis for a rare disease. So clearly we have a lot to do, and newborn screening is definitely one of the tools in that armory that we should be, I guess, leveraging more to try and identify people, or at this stage would be children living with rare diseases before they become symptomatic. The campaign itself, we have a website, getrareaware.ie, and we would ask everybody to please do go onto the website and take the opportunity to take action. Pop your name and your email address on at the website, and it will send an email automatically to your elected representatives in the health region that you're living in, essentially. And just ask them to, take note of this campaign, and to ask the minister, what are we doing to help to expand newborn screening? So just in terms of newborn screening, we currently screen for 9 diseases. There are another 2 that have been recommended for inclusion in the newborn screening panel, and I guess work is ongoing in the HSE in that regard. But we're way behind Europe. We're actually in the lowest 25% in terms of the amount of screening that we're doing compared to our European counterparts. There are estimated to be probably something in the region of 200 newborns would be diagnosed through newborn screening if we were screening on, screening more, doing more screening, maybe screening for 20 or 25 different rare diseases. So if we, ramped up, we will be, I guess, identifying many more newborns and giving them access to early treatment. The process at the moment is a 2-step process. The first thing that is done is, I guess, recommendations are made to the National Screening Advisory Committee to add a rare disease to the newborn screening. And they will go away and, I guess, work out, look at all of the research in the background and understand, is this really suitable for newborn screening in Ireland? There are, as I say, there are many diseases that are screened for in other countries that aren't screened for in Ireland. And so we're I guess, applying appropriate pressure on NSAC to try and ramp this up a little bit, that we can start to screen for more of these conditions. The next step then is the HSE step. So once a recommendation is made by NSAC, the minister will then confirm that recommendation and pass it on to the HSE. And at that stage, then there is work to get the lab up and running. And in parallel, there's also work to ensure that we have, I guess, pathways. So if a newborn is diagnosed with a particular rare disease anywhere in the country, that they find their way to the specialist within hours or days, that it's not well, now you go to your GP and now you go here, now you go there, that there is a very direct pathway to the specialist expertise. And I guess that's where we would bring in somebody like Ellen would be part of that specialist expertise community in terms of consultants in hospitals. Finally, I would say just around the NSAC piece, there are over 30 rare diseases on the list that they are working through at the moment. As we say, we'd like to see the speed of that work ramping up. And we would hope that as a result of this campaign, and it will certainly be part of our manifesto for the next election, which will presumably be autumn, winter, early spring. Well, it'll have to be at latest early spring next year. But we would like to see that this would be part of it, and that we would be at least asking that the amount of newborn screening would at least be doubled to bring us up to just above the current European average in terms of newborn screening. But, this is a very worthwhile investment. The systems are in place. The treatments are being provided already today. But sadly, the children living with some of these conditions are symptomatic before they're actually being provided access to treatment and care that is needed. Without further ado, I'm going to ask Ellen to unmute herself and bring her into the conversation. Thank you very much for coming along today, Ellen. I know you have a busy life there, as do all of the clinicians in the country, I suspect, at this stage. I guess my first question would be, what does newborn screening mean for you, for your patients, for your clinical practice? You know, why would you like to see more newborn screening?
Okay. So I suppose I should introduce myself. My name is Crushell. I'm a metabolic pediatrician. I work here in Temple Street, and this is where the National Centre for Inherited Metabolic Disorders is based. And it's been here for a long time. It's called St. Ultan's Unit because it was funded from proceeds from St. Ultan's Hospital, and the only proviso that was attached to the funding was that it be called St. Ultan's Metabolic Unit. So hello from St. Ultan's Metabolic Unit. So all children with inherited metabolic disorders are referred here to myself and my colleagues. We're consultant metabolic pediatricians, and we've all trained in pediatrics and in inherited metabolic disorders. So a certain number of our referrals will come to us through newborn screening. So of the 9 conditions that Vicky has mentioned, and thank you very much, Vicky, for this campaign and for highlighting it, because I've seen the work last year around genetic services, and things are steadily improving in genetics, and we see it on the floor here, and it's great. So I'm sure your work has helped to contribute to that.
Thank you very much.
So children come through different pathways to us, to me, to my clinic, to our inpatient ward here, St. Bridget's ward. We have a specialist metabolic ward, through slightly different pathways, or a number of different pathways. But one of the routes, and I suppose the most hopeful route, is that through newborn screening. So you all know every baby is offered newborn screening, and the take up of newborn screening is really high in Ireland. So there's a real confidence in our newborn screening program, and it works well as a system. The sample is taken from the baby's heel between 72 and 120 hours of life. So that's day 3 to day 5 of life. And that timing is important, but because the baby needs to have had some feeds, and there are a couple of other nuances there. But if that screen, the blood test is taken onto a card that arrives in Temple Street the next day and is analysed for 9 conditions. Of those 9 conditions, 6 of them are metabolic disorders. And in fact, the original prototype for all of newborn screening was PKU, and we've had a screening program for that in Ireland, a national screening program in Ireland since 1966. So if the test is positive, so if for PKU, if they detect that there's a high phenylalanine in the sample, we get a phone call, and there are a couple of systems in place. There is a system in place for that child to be seen quickly, for the diagnosis to be confirmed, for the various treatments to start. So that's one of the 6 disorders. So it is an effective way of detecting metabolic disorders. For some metabolic disorders, there are other disorders that might not be suitable for newborn screening, but certainly for the ones that are on the system, it is effective. We diagnose the children oftentimes before they're symptomatic. And then we can start treatment, so to prevent in PKU, to prevent them ever getting symptoms. And the symptoms you might expect in PKU, if it wasn't treated or detected at an early stage, would be learning disability, epilepsy, and being dependent for forever, essentially, in classic PKU. So we can prevent all of that, so that through dietetic treatment. So I have a dietetic team here within the Metabolic Centre, and we provide kind of holistic, multidisciplinary care through our team here, to support parents in teaching them about the diet and monitoring levels. It's very intense, and it is not easy. So it's a big ask of parents. But the reason we do all of that is because it's worthwhile. That child, if they're detected at an early stage as having, for example, PKU, they will go on, they'll be on a specialized diet, but they will go on to have, an academic and they will go to school like the other kids. They will, achieve like their siblings, and they'll grow up into healthy adults.
Lead a relatively normal life, whatever normal is at this stage for us. And I think actually, PKU is such an interesting example for us here in Ireland because we were one of the first countries in the world to introduce newborn screening for PKU. And look
Yes.
at us now, it's so kind of like, oh, where did
Yeah.
we went so right and now we've gone so wrong. And only recently we had actually some of the work around the development of the new National Rare Disease Plan. And one of the attendees at one of the webinars we were having was saying, yeah, I was one of the first kids ever diagnosed with PKU in the country. And here she is now, as you say, leading a normal life, contributing, having her say and things like that. And things could have been so different had she been born a year earlier or something like that. Could be a very different outcome for her. So really, there's a lot of good to be seen in the newborn screening stuff, definitely.
For sure.
Yeah. So tell me, Ellen, of the 30 plus, I guess, conditions that are on the NSAC list, and I should let people know that you are a member of NSAC, still a member of NSAC, but maybe not for too much longer because your term will come to an end relatively soon. But of those 30 conditions, how many of them do you think are in the metabolic world? How many more would you like to see from your
Uh,
medical practice?
Let me think. So, you know, of this, I'm trying to think through it's nearly easier to think of the ones that are not metabolic because there are only a small number, less than a
Yeah,
handful, not metabolic.
yeah,
The rest would be metabolic disorders. Now,
yeah,
none of them are common, and that's fair to say. And we could go, for some disorders, we could go a year or 2 years without detecting a case. But already within newborn screening, we screen for a disorder called maple syrup urine disease, which is quite rare in Ireland. So we often go a couple of years without detecting a case. But when you do detect a case, it is life saving
yes,
and altering to be able to treat them. And um, but for so of the if you were to look at another screening country where they might screen for 30 disorders, the vast majority would be metabolic disorders.
would
So
be yeah.
where you're searching for a particular metabolite that is high in that neonatal period that you can detect and bring in a treatment to keep it under control.
Yeah. And it must be, quite frustrating for you as a clinician to see a child that's coming in that's already a couple of weeks or a month or two old or whatever, and kind of think,
Yes.
we could have if this had been available to us, and by dint of the fact that you have slightly different genetics, you haven't been offered this. And I guess it is one of the things that we would certainly say, the equity around the system. We have the care, we know what to do, there is technologies available, but it's just the system isn't equitably applying all of the science and advancements to everybody, to every citizen of the country, I guess.
Yeah. And as some of these kids go to ICU, like they can be extremely sick by the
Yeah,
time, that they come to hospital in extremis as newborns, or they could be a month old, or sometimes it's they get through that first month, and then they might be 6 months old when they have their first infection, and then they get extremely sick, or and end up in ICU, and then they're comatose. They may have neurological problems. So all of that could be prevented if they had been detected as a newborn and the treatment started and emergency
yeah,
put in place for when they do get sick, which is what
yeah,
we talk about some of the disorders. Yeah.
yeah,
So it is difficult when we have a child come in and we think, oh goodness, yeah, this
yeah,
if we detected this, we would have known about them, and we would have prevented this
yeah.
episode. Yeah.
Yeah. Very, very difficult. So tell
And
me then a little bit about your work. Sorry, go
yeah,
on ahead.
I was going to just the disorders are the treatments are not, for many of the disorders, are not that different to what we, for the metabolic disorders we already screen. We're not talking, they're well established. We're not reliant on fancy new expensive drugs. It's
Yeah,
mostly dietetic treatment, metabolic treatments, straightforward, not expensive,
yes.
which is an interesting point. Yeah.
Yeah. No, absolutely. If I'm like, I guess the cost of doing this screening is actually just that piece,
Mm.
because in fact the cost of providing, as you say, it's not uh these new gene therapies and stuff, which I'm all in favor of as well, but it's not this vast cost of a new therapy. It's actually management of diet and stuff like that.
For
and
many,
and you,
there are
I can only imagine from a parent's perspective to think that I could have done something differently as a parent when they were small, and now we have this, and the psychological impact of all of that kind of, oh, I don't even want to go down that. There's a can of worms there. I suspect that one could really, it is very hard, I think, for families, and it's not that getting a diagnosis is easy at newborn. At newborn stage, everybody has this dream of kind of like it's going to be like this, and they're going to play football or hockey or rugby or do all of these different things. And then to suddenly, oh, that's not what I had planned for the next year or 6 years or 10 years, is not going to be the way it is. But, I think I have spoken recently to a mum who was talking about, at least I know I'm doing as much as I can right now. I'm empowered to be able to do things because I have this knowledge and information. Whereas if I don't, I'm then, I'm at a complete loss, as my child maybe isn't doing as well as other newborns around them. So tell me a little bit about your work then at NSAC. I don't want to betray any confidences or things, but I guess how do you find it? How is NSAC? I guess NSAC arrived for people on the webinar. NSAC arrived as a result of the cervical check scandal. It was one of the Scally report recommendations was that we needed to, I guess, put in place the structures to make sure that screening is well managed and that it's a thoughtful process, that we're not just doing things willy-nilly. So what's it like there?
Well, it's great. The thing about NSAC is you have to remember, before NSAC there wasn't a process to get things approved. So even though to you and to us things seem slow, at the same time, to think that we've managed to get SCID and SMA added, it's hard to see how that would have happened before NSAC, to be honest. There wasn't a straightforward process. We had been asking for 2 disorders to be added for years and years. And those are the 2 disorders that were added in the end of 2018, early 2019. But that took a long time, and they were the first disorders to be added since the 70s. So that took a lot of pressure. It was a difficult process to get them added, and they happened. But now there's a more streamlined process that's evidence backed and supported by a lot of HICWA investigating into it, which has to happen, which is great. So I sit on NSAC, and I'm on it since the start. So I'm the child health representative on NSAC. So there are representatives from the different areas, from radiology, from lots of different areas, and patient advocates too. And it's a very interesting forum. There's a lot of expertise around the table that takes into account various nuances that a group of metabolic pediatricians might need to think of if we were tasked with the decision making. So it's very good in that respect. It's been interesting to see the work that HICWA does is very, very in depth, very detailed, very inquisitorial, and that is, a very informative process and very valuable for NSAC. It's good. And at one of the very first meetings, newborn screening has been on the agenda since day one. The expansion of newborn screening. So that's certainly one of the key things that's on the agenda. And Les Martin gave a very eloquent presentation early on, and he's I'm sure Les, he's advocating for expansion of newborn screening. And so since then, I think it has been on the agenda, and it is working through, but it's that last push.
And again, for listeners, Les is a parent who had 2 children living with a rare metabolic condition. One of them has sadly passed away, but the second one is doing very well, in fairness, doing very well following getting access to a clinical trial. When that son was being treated in Italy, Les came across newborn screening in Italy and was just kind of come on, Ireland, we need to be doing something about this. And he has been banging this drum and lives in Wicklow and has bent the ear of our current Minister for Health, our current TD, or our current Taoiseach. He's really been very active, and I would have to say has really been transformative in terms of I guess the awareness and the understanding around newborn screening for a lot of people, very definitely. One
I
of the
think,
things I do find, sorry, Ellen, what were you saying?
yeah, and I think there's political will. There really is.
Yeah,
So it's just so that's all good. So I'm very
yes.
hopeful that we'll get there. Yeah.
Oh, well, I have no doubt. I have no doubt that we, but we will. Certainly, if I keep banging this drum, eventually somebody in the HSE at a senior level will be like, just make her go away, just make it happen, please. We're tired of listening to her. One of the things I guess that, when we had our campaign last year around genetics, and now it's newborn screening this year, and as I say, the information around the diagnostic odyssey for people living with rare diseases in Ireland, there's a lot of, I guess, hype, dare I say it, and maybe you'll just tell me this is not your field at all, but around the idea of, I guess, whole exome, whole genome sequencing and newborn screening and the benefits that we could derive from that. I think that maybe as advocates, we sometimes forget about actually, ethically speaking, should we be doing some of this? What's the impact? I mean, I was part of an original HICWA review of just newborn screening systems generally. And I was really intrigued, as you say, with the people around the table when they started to talk about the ethics of screening healthy people and what's the impact. And I know from talking with some of your colleagues in the HSE, in the newborn screening world, they're very concerned that we would damage the good reputation of newborn screening, and that lots of parents would start to opt out and things like that, that could have a very negative effect. And I wonder, I'm guessing that is probably a lot of the conversation that you have around the table in NSAC is around what should we be doing? What could we be doing? Yes, we can analyze lots of these and add lots of things, but what else do we need to do to make sure people are with us on this? It's not just about the technology and the science, it's also making sure that the population is with you.
Yes, and I think that's a key piece. And in England, they're going through that at the moment because there is a project going on in England where they are doing a screening of newborns. Now they're doing, I think, genome sequencing, but they're concentrating on 200 disorders. So the it's very difficult because it throws up all sorts of questions, and the clinical community are quite concerned about it.
Yeah,
Because you have to think of it from the point of view as well. Okay, you might pick up some rare diseases, and that'll be clear cut, and some of those will definitely benefit from being picked up. And then you'll have the people who where nothing was picked up, but there'll be a grey area where there is a baby that is either completely healthy but has this genetic variant and nobody quite knows what that means and whether the child might or might not get symptoms. And you're giving this sentence to that family and not
yeah,
really knowing, not knowing enough that whether the variant is actually what we say pathogenic or disease causing or not. Because we all have, differences in our genetic alphabets, and those are called variants. And some of those variants are problematic in that they can cause disease, and others are not. You just live with them and you don't know you have them and you're fine. And there can be an in between where there's a variant that may be pathogenic but might not actually give you symptoms until you're 55, but we've no way of knowing that. So you've altered that child's life by putting this on them. So there's a lot of nuances to that and ethical issues. And you also have to look at it from the healthy child's, the family who gets that call back, oh, there's a variant. And then they're listening to this for years while being followed up, but people aren't quite sure what they're being followed up for and whether they need to be followed up. And yet there may be a healthy child there in the middle of all this.
yes, yeah. And I think with that kind of stuff, it's very undermining of the healthcare system as well. There's kind of it undermines trust in what you're hearing, because, well, you told me the last time that you didn't really know, and now you know nothing, and now why would I bother engaging at all? And so there's a lot of as you say, it's just, yeah, it's a
The
big,
genetic advances have been huge, though, from our perspective. When I joined here as a consultant in 2009, there were a large cohort of patients that we thought had a metabolic disease, but we couldn't tie it down for
yeah,
certain. The vast majority, not all, but the vast majority of those now have a genetic diagnosis because the
okay,
advanced genetic testing, all of our diseases are genetic. The metabolic
yeah,
diseases are all genetic. The advance in genetic testing, including exome sequencing and genetic research, have been huge in terms of getting diagnoses for people who have rare diseases that didn't have a diagnosis. So that's been very helpful, and it's
And
becoming
has that changed? Has that information changed your management of these people, or is it
absolutely.
impact? It has, yeah, yeah, yeah,
When I joined here, there was a waiting list for muscle biopsies. We used to do muscle biopsies on children we thought had might have a mitochondrial disease to try and help us figure it out little bit more, which was an invasive test. It required this is just an example, but it required a general anesthetic. And now we very, very, very rarely do a muscle biopsy. We just we skip that altogether because
yeah,
getting the genetic diagnosis is more helpful.
yeah.
So yeah, so we, you know, and in fairness to the health service, that is all funded. We send exome sequencing, you know, regularly when we don't know if
What's
when
going on?
we have
Yeah.
a case that was complicated and it looks like there might be a genetic element to it.
Yeah, yeah, yeah. Okay, very interesting, very interesting. Gosh, I'll have to come back and learn more about this now. One of the things that when we were talking yesterday, so Ellen and I had a chat yesterday just to prepare for today. You spoke very much about, I guess, the raison d'être for screening in this country, and I guess as a patient advocate, we would say, well, we should be doing more screening because it's not just about the treatment that you can provide. It's not just about that. It's also about the information that's then provided to the family, and future family planning, and lots of different things. But you were saying to me, really, the system that we have today is very much built on the benefit for the individual child that is being screened. That they don't look at the wider picture. So tell me a little bit around the history of that, if you have any,
Well,
as to why.
well, I suppose this is one of the premises of screening. The individual has to benefit. You know, if you're
Yeah,
going to detect something, there has to be a reason to detect it. The child or the person who's undergoing the screening has to benefit from that. And it's
yeah,
the same premise for breast screening, breast cancer screening, or cervical cancer screening. So you screen on the premise that the individual that you detect is going to get some benefit from it.
yeah.
For example, we don't screen for something that's untreatable.
Hmm.
So for and because is there any real benefit to the child? You don't have a treatment. You can't give them anything that will reverse that
Disease
disorder.
course.
Yeah.
Yeah, yeah, yeah.
Uh, Yet if you were to think about it, well, there might be benefit to the family in knowing, because they might, plan the rest of their family better, in a different way, or there might be implications to the wider family. But that's not a premise for screening, and that goes back to the kind of original criteria that were written by Wilson and Younger. That kind of, they set out I can't remember how many points, about 10 points, how there should be a reliable, easy test that can be done for big numbers. There needs to be benefit to the individual, so there needs to be a treatment, an approved treatment, and all of that. So those criteria are what guide screening programs appropriately in
Yeah.
our and in most of the world. Although in I think some areas, some of the states might be starting to think outside that, but
Yeah, yeah,
I think
yeah.
here we probably should continue to focus on the benefit to the individual for now. Yeah.
Was certainly, I guess, in the short term, given where we are today, maybe in 10 years' time, this will be a slightly different conversation. Because I certainly know that there is, I guess, a call from some people. These are actionable
Mhm,
conditions as opposed to treatable.
mhm,
That maybe there are things that we could be doing differently that wouldn't necessarily be a direct treatment, and as you say, for family planning and stuff like that. But that's not the system today, and there's plenty of work to keep us going over the next few years to get the 30 plus that are on the list approved. And and I would have to say, you spoke about SMA being added, and hopefully it'll go live in the HSE not too far away. But I guess when one thinks about it, 5 years ago there was no, sorry, there was some therapies for SMA, nothing like what we have today in terms of a gene therapy potentially curative, if the clinical trials data are to be believed. Um, is there anything like that coming down for metabolics that you're aware of? Is that kind of where things are headed, do you think, or just out of the pure research science piece?
For sure. I mean, there are gene therapy trials happening for a lot of metabolic disorders,
Yeah.
and we've had the approval of Libmeldy, which is the treatment for MLD, and that's approved now in the HSE. So there will be more like that. There
Yeah.
are therapies. Our colleagues in England say that while there's so much in research, it does then require a drug company to actually take it on and take the next steps to getting it approved and all of that. So I imagine it's still a while away for many of them. But one of the disorders that is prevalent in Ireland, more prevalent in Ireland, and particularly in our traveller population, is Hurler syndrome.
Yes.
So at the moment, children who are detected as having Hurler syndrome require a bone marrow transplant or a similar using cord blood. And that happens, the younger the better, essentially.
Yeah.
The younger they are at the time of that transplant, the better they do in the long run in terms of their brain health. So these children are generally picked up clinically, or sometimes there's a family history and they're picked up a little bit earlier than you might expect. And they're transferred for a bone marrow transplant. That currently happens in Manchester, but that bone marrow transplant is going to be compared now with a gene therapy. So in a couple of years' time, gene therapy may be superior and not as dangerous for those children as a bone marrow transplant. So this is an exciting time, and we will, we're obviously collaborating very closely with Manchester because all our children with Hurler syndrome go there.
Yeah. It is interesting because I guess again last year when we were doing the genetics piece and we see I've been in this world and actually in the industry side for a long time before I came into Rare Diseases Ireland. But as part of it, it was kind of like, oh, personalized healthcare and things like that. But that's what this is, really, we're the cutting edge, we're the leading edge of what's going to be eventually personalized healthcare, one
Yeah.
presumes, but that might be another 40, 50, 60 years away, but it is heading in that direction when you start talking about gene therapies and being able to provide treatments at a young age and stuff and prevent disease from really happening. I have not. Let me just check the Q&A and see if I have any questions. If anybody has any questions, please do pop them into the Q&A now. I might just give people a minute or two just to see if anybody has any questions. Maybe while I'm waiting, maybe tell me a little bit about the metabolic service. What's going on in Temple Street these days?
So we're busy here. This is the Metabolic Centre for Children, and our colleagues up in the Mater have an adult service. So what's interesting about metabolic disorders is for all the other specialties within pediatrics, they would have started as specialties in the adult world, for example, cardiology, and eventually there would have been a pediatric cardiology specialty developed. So it's the other way around for metabolic disorders because they have kind of classically been childhood onset diseases. The kind of specialty grew in pediatrics first, and the adult have followed suit. So the centre is for adults is in the Mater, and our patients transition here to there between the ages of 16 and 18 usually. So we had a lot of adults on our books until the last couple of years, until that centre kind of got built up. We have about, I think, 1,200 patients with inherited metabolic disorders here. They're all rare, although we do have. We also have a little bit of familial hypercholesterolemia, just because there's some families with very bad cardiovascular health will come to us for early management of familial hypercholesterolemia. So that's the only non-rare disease that we really look after.
Yeah.
The children can present at any age with a wide variety of symptoms. So we have a lot of toing and froing in Crumlin, and two of us have sessions in Crumlin as well, where we see children with heart disease, liver disease, where we do have cardiology here, but most of cardiology happens over there.
Yeah.
So there's a lot of toing and froing. So the new hospital will be so helpful in that regard. All the specialties will be on one site, and we'll have an electronic health record, which is scary but very exciting, and we'll start with information sharing and all of that.
Yeah.
very closely with genetics. So we have a nice multidisciplinary team here. We have clinical nurse specialists, a metabolic ward, which is a real luxury, and other centres don't have that internationally. We have very close international links. We'd be one of the biggest metabolic centres in Europe just by virtue that our population has a relatively high incidence of metabolic disorders, interestingly, compared to other populations.
Is that across all metabolic disorders, or is that driven by one or two conditions?
No, the interesting thing is we have, if you take the whole population and say how many of the Irish population have a metabolic disorder, that in itself is high, but I think that we haven't had as much invasions of other populations over the centuries.
Yes.
So if you take two unrelated Irish people here, they'll have a lot of genes that are in common, whereas if you take two unrelated Americans, they have a lot less genes in common. So just the genetic pool is a little bit smaller in Ireland. And then we have cohorts within Ireland that have a much higher incidence of metabolic disorders, and they would include Roma community and the Irish traveller community. So both of those communities have a very high incidence of certain metabolic disorders, and then they have none of other metabolic disorders. It just depends on the gene pool. Over the last decade, we see children coming in, that have parents from other ethnicities that have really expanded our range of metabolic disorders. So that's been very interesting. Disorders that we hadn't dealt with here in Ireland before, we now see just different genetics.
It's fascinating the way it all changes. I have a question in which is semi-specific, and I don't know that you'll be able to answer it. And if you don't know what's going on, just say as much. Somebody's asking about sickle cell screening, and I know it's part of that list of 30 plus.
Oh yeah.
Is there anything going on with it? Do you know? I don't know of anything. I suspect it's not.
It's absolutely one of the priorities with NSAC. It would have come in through the annual call for sure, and would be part of the newborn screening governance group's priorities. So that would be one of the top conditions to even though we're chatting, Vicky, as if you could just add them all on, and in some ways you could add them all on quickly. There is so much work with adding each one. Like you mentioned, the clinical pathways have to be tied down. It all has to be smooth and seamless for the families. The laboratory element of it, there's a huge amount of work in each disorder in terms of validation, and even in the kind of quickest systems in the world, it seems to take at least 18 months to get any disorder added, and that's not just an Ireland, interestingly enough.
And again, one of the conversations I was having with people, some of your colleagues in there, was kind of like, it's all well and good comparing us to maybe the UK or France or Germany, but actually they have 5 or 6 newborn screening labs. They can dedicate a lab to doing this. We have one, and we have a service that has to be delivered. And then on top of it, we're now trying to add these other things. And you cannot just switch something off for a week and say, let's just do this instead. That's not an option. And so it will naturally take longer.
It's very specialist work. Like, there are very few qualified metabolic pediatricians. There are very few metabolic scientists. You can't just kind of go out tomorrow and get another consultant, even if you had all the funds, those kind of posts, there isn't a ready pool of people ready to jump into jobs, for example. But
this brings us back again a little bit to the development in the National Rare Disease Plan around the education system, right back into medical school, and not just for the medics, but across the whole healthcare service, that actually upskilling people on rare diseases and making it. And I think, from our perspective, certainly from my perspective, having come out of industry into this, it is one of the really interesting areas of medicine and science, rare diseases, metabolic, all of these things, because it is cutting edge. It is where all of the investment really is going at this stage. There's only so many variations on a stent that can be done, or on a statin or something like that. It's kind of, actually, this other stuff is really cutting edge, and hopefully, as science continues to develop, that it will, I guess, bring more clinicians and more skills and people into this area. AI, I think, is really another whole ethical question, I suspect, around the use of AI and some of this stuff. But it will happen, and it's how we manage it and how we I guess the how we are all seen as being adults having these conversations, rather than two or three people saying, "Well, we'll just do this over here," and there will be bad actors, but there will be lots of people. That are very logically and carefully thinking through the use of all of these technologies. That was the only question that came in. And in the interests of everybody's time and maybe some empty tummies and stuff, people looking for a bit of lunch. And of course, Ellen, I know you probably have a queue of patients sitting outside the door there, hopefully not waiting too long. But listen, thank you so, so much for coming along today and for speaking with us. It really has been very interesting and eye opening. And I really, I think that there's a lot going on. Newborn screening is but one area that certainly we're looking for advances in. But I think for you guys, in terms of your medical practice, for you and your colleagues, and then when we throw in on top of it, move to new hospitals and things like that, it's going to be a really busy time ahead. But I think hopefully very exciting. Hopefully, in 5 years' time, we'll all look back on this and say, "Wow, that was hard work, but it was well worth it." And look where we are now. So I really do want to thank you very much for your time. And before people leave, just a quick reminder, getrareaware.ie, please do take action. And Ellen, you can take action too, and your colleagues there. Go out and shout it from the rooftops. But please do. It's really quick and easy, and it just helps to raise the profile. And I think this year of all years, as we're coming into a general election, it really is important that, if you do meet, if there are candidates knocking on your door, ask them what are they going to do for people living with rare diseases. Because as a country, we still have a lot of work to do for the rare disease community right across the healthcare system and across other social supports and things like that. But let's at least make them aware that there are needs and that we really do want people to get moving on this. So listen, without further ado, thank you very much to everybody, and thank you very much, Ellen, for your time today. Take care. Bye-bye.
Thank you, Vicky. Bye now.
Bye.